This is Angela Walker. This is for treatment case 2. I have chosen Mary, a 26-year-old female. She came to our office today in search of help for her diagnosed borderline personality disorder. She has been contemplating suicide, engaging in sexual activities that she is not proud of, and is reaching out for help to control her anxiety, reckless behavior, and obtrusive thoughts. The primary concern for Mary is her mental health and how it impacts her abilities to interact with others and navigate various social situations. Her diagnosis sheds light on the challenges she faces in regulating her emotions and maintaining stable relationships. Mary has difficulty in regulating emotions, unstable relationships, impulsivity, and identity disturbances that significantly impact her daily life and functioning. Mary was put up for adoption when she was a baby. She was able to locate her biological parents after she turned 18. She found that her parents gave her up for adoption because her mother suffered from borderline personality disorder and her father was abusive. Mary was placed in foster care and experienced trauma and sexual abuse. When she was finally adopted, her family life was very stable and supportive. Mary's adoptive parents were aware of the family history and supported Mary with therapy and family counseling until she graduated from high school. So Mary does have a high school education, has worked in numerous administrative positions for different companies. She has difficulty holding jobs for extended periods as she fears that her employers are weary of her behavior and lack of emotions. She does not feel included at work, which causes her significant distress. Her employers describe her as being short with customers on the phone, and when dealing with individuals face-to-face, Mary can become angered quickly. Her social history: she has a boyfriend who has been supportive of her. She buys him lavish things for fear he will leave her and sends multiple texts throughout the day. And unfortunately, she does yell at him for no reason and will throw things at him. Previously, she engaged in promiscuous sexual interactions with individuals she didn't know, and Mary will change her appearance to fit in with the group she is currently associated with for acceptance. She has not had a best friend or a friendship that has lasted longer than a year. Her medical history and psychological history: Mary describes that she's had these feelings of worthless since she was younger. She has attempted suicide twice, both were unsuccessful. She feels that she's constantly thinking of a way out and ending her life. She was diagnosed with BPD when she was in high school. Her adoptive parents noticed her erratic behavior and wanted to get answers and help for their daughter. They noticed she didn't have friends and felt isolated. Her adoptive parents wanted to make sure she was safe and also to end her cutting. Mary was treated with dialectical behavioral therapy. However, she did not finish this therapy process. Mary is found sitting in an office chair. She's emotionless, alert and oriented, and she's aware that she gets anxious and overstressed, and she will zone out even if it's in the middle of a conversation. She has cuts to both arms. Some cuts are new and some are old and healed. Mary has expressed that she's attempted suicide and she can't stop thinking about ending her life. She is aware that her behaviors interfere with work, which is why she changes jobs so frequently. She feels shame for the way she has acted. She admits to having no friends other than her boyfriend, who she likes very much. She's been supportive and understands her. By examining Mary's emotional instability, impulsivity, and turbulent interpersonal relationships, clinicians can formulate a diagnosed impression that aligns with the criteria outlined in the DSM-5 for borderline personality disorder. The diagnoses that I have chosen are borderline personality disorder, personal history of physical abuse in childhood, personal history of sexual abuse in childhood, personal history of self-harm, and other personal risk factors. My differential diagnosis is depressive disorder due to another medical condition with depressive features, social anxiety disorder, post-traumatic stress disorder, anxiety disorder due to another medical condition, unspecified dissociative disorder, and disruption of family by separation. The causal maintaining factors: it's essential to consider the interplay of genetic predispositions, early childhood experiences, and environmental influences that may precipitate the onset of BPD. The study highlights the role of interpersonal relationships and emotional dysregulation as critical elements that only exacerbate her symptoms but also perpetrate the cycle of distress. Biological contributions can have causal factors. Barlow states important genetic studies are investigating genes associated with the neurochemical serotonin because dysfunction in this system has been linked to the emotional instability, suicidal behaviors, and impulsivity seen in people with this disorder. The regulation of mood and impulsivity has been found to be associated with decreased serotonergic activity, prompting extensive investigation within this population. Socially, according to Barlow, symptoms of borderline personality have been observed among people who have gone through rapid cultural changes. Individuals with BPD often perceive their environment as hostile and exhibit intense reactions to both actual and imagined threats. The treatment plan. I would start with BSL 95 borderline symptom list. This starts a good list of items that show changes throughout treatment. The BSL 5 is also concurrent with the DSM 5. I would then move on to the screening for borderline personality disorder using the Personality Interview Questionnaire 2, PIQ2, a self-rated questionnaire. I would then follow with the Personality Diagnostic Questionnaire 4th edition, PDQ4, and then I would follow up with the Wisconsin Personality Disorder Inventory, a 204-item 10-point scale. This questionnaire has high internal consistency and is great for retesting. I would then follow these questionnaires with a structured clinical interview, followed by the DSM-5 Axis 2 personality disorders, and then I would end with a clinical interview to confirm the diagnosis and observe any behaviors. I will also encourage Mary that her treatment can be successful, according to Crody et al. Although most of the individuals with BPD experience symptom improvement during adulthood, with about 85% reaching diagnostic remission within 10 years after diagnosis. Since Mary has already started therapy with a dialectical behavioral therapy, I will choose a different option. I will discuss with Mary the options of therapy since there are new treatments. One is mentalization-based treatment for borderline personality disorder. MBT is a time-limited treatment that structures interventions that promote the further development of mentalizing. Another new therapy is schema-focused therapy, which is an inclusive method based on the fundamentals of cognitive behavioral therapy. It has subsequently been broadened to encompass methods and ideas from other forms of psychotherapy. Schema therapists aids individuals in altering their deeply engraved self-destructive behavioral patterns through cognitive, behavioral, and emotion-focused strategies. My recommendation would be for Mary to engage in mentalization-based therapy. It focuses on addressing suicide and self-harm, emotional processing, and relational instability. And it also includes group therapy and improving their capacity for mentalizing and social learning. This treatment progress. So Mary agreed to participate in the MBT as suggested. The great thing about this therapy is it includes group therapy sessions. This allows Mary to see that she's not alone as she can trust others. According to Ring, BPD is characterized by imbalances in mentalizing as expressed in high levels of automatic, effect-driven, and externally based mentalizing, and frequent loss of the capacity for balanced mentalization, particularly within close interpersonal relationship. MBT has 3 phases. The initial phase involves psychoeducation provided through an introductory group course, case formulation developed collaboratively with the patient, a focus on developing a treatment alliance based on an understanding of the patient's attachment history, safety planning, formulation of a mentalizing profile, which includes the identification of specific imbalances in mentalizing, including triggers of mentalizing problems. The second phase includes specific strategies for dealing with the daily struggles of every life. The final phase is where the therapist and client in the relationship. This could trigger a fear of abandonment for the patient. It is encouraged that the patient can reach the therapist for any follow-up treatment. This process lasts at least 3 years. Mary handled this treatment quite well. She graduated from the program and has held a job for 3 years while receiving treatment. She also ended up marrying her boyfriend, who was very supportive and even joined group sessions to get a better understanding of Mary's illness. And she lived happily ever after. Thank you and have a great weekend.